We are ready to roll, Deb.
Okay. Good afternoon, everyone, and thank you for joining us on our first webinar focused on impacting the opioid crisis in our nation. I'm Debbie Nansen, the Project Director for the Virginia Cardiac Services Quality Initiatives Support and Alignment Network 2.0. That's a mouthful. This session is being recorded, and hopefully those of you who either joined in late or weren't here live are able to access it and listen to the full program. Please feel free to enter any comments or questions in the chat box throughout the afternoon. I'll show you up here if you don't know where the chat box is, looking at my screen. Over here and more, and chat is down here. Okay, so today's agenda is organized around our objectives for the webinar as seen here. We have several guest speakers who will cover general topics. These are high-level discussions, and we certainly will want to know from all of you if you would like to hear more about any of them or other related topics. Questions to run on. On national webinars sponsored through CMS and the TCPI project, we are often given questions to run on. These are things to think about during the webinar. So we've offered a few here for your contemplation throughout. Think about how your practice is currently prescribing opioids, how it potentially could improve your prescribing practices. Can your practice participate in measurement activities requested by us? And you'll see those potential measures later on. And what else would you like to hear more about? So let's get started. I'm pleased to introduce Dr. Jeffery Rich, who serves as our Chief Clinical Advisor in the VCSQI SAN. He also was the author of our proposal that awarded us this contract. He's former president of the Society of Thoracic Surgeons and former director of Medicare Services at CMS under the Bush administration. He currently is the chairman of operations and strategy for Cleveland Clinic's Miller's Family Heart and Vascular Institute. Dr. Rich, the floor is yours to set the background for our webinar with a brief overview of the opioid crisis in our nation.
So Debbie, I'll have to have you advance the slides for me. I'm looking at my picture. So the next slide, please. Yep, it's up. Thank you. Obviously, there's an opioid crisis in the United States. There's no doubt about it. It's everywhere I go. If it's at CMS, if it's here at the Cleveland Clinic, it's every place people are talking about the opioid crisis. Next slide. Done. So 91 Americans die every day. That's a startling number, if you would. Next slide. That translates into one person dying every 19 minutes from opioid abuse. And the pain relievers are responsible for more overdose deaths than cocaine and heroin combined. So it's a startling figure as well. Next. So this is a slide I like. This is Dr. Cosgrove's slide he uses. It's a picture of the Vietnam memorial, the war memorial. 54,000 soldiers died through the entire Vietnam conflict. 62,000 people died last year from opioid overdose. So it's obviously, I mean, we all were very sensitive to the deaths in the Vietnam War. Now we're talking about more deaths on an annual basis than the entire Vietnam War described or was attributed to the overdose. That next slide, the death trends are listed here. They're rising, and it's fairly linear, and I'll let the experts here on the call speak to this. And if you go to the next slide, Debbie, the increase in opioid prescribing coincides with increases in the opioid overdose deaths. So the top line, the red line, is just the number of morphine equivalents in kilograms per 10,000 population, which is a hard number for me to wrap my head around. But the opioid overdose death per 100,000 population has not ceased to climb over time. Next slide. Yep. The changes in prescribing, just generally, and I think others might support this, that 85% of people addicted to heroin started out with an opioid prescription from a physician or a provider. And the length of prescribing that you do, the number of pills that you give, will clearly depend on your abilities to become addicted. So go to the next slide. I think this is fairly poignant. So the 1-year probability and 3-year probability of addiction depends on the day's supply of the first opioid prescription. And that's why there are movements now, and I think we'll hear more about it, that only 5 days worth of opioids be prescribed at any one time. And the second graph basically shows that people who are naive to opioids, if you give them more than one prescription, you're pretty much on a pathway to addiction for them. So next slide. I'm sure everybody has a story like this. You know, I've had friends who had children die from opioid addiction. I live in an apartment that's full of young people. They're all millennials, and I was coming home from work and walked into my apartment building, and they were taking out a millennial in a body bag from an opioid addiction, for overdose. So it's everywhere, and it's something that we need to address. And I will stop there, Debbie.
Thank you, Dr. Rich. In June, CMS asked all of the organizations contracted as part of the Transforming Clinical Practice initiative to also take on the challenge of addressing the opioid crisis with our participating practices and clinicians. We've been asked to raise awareness and encourage prescribers to review their current practices toward reducing unnecessary use of opioids and minimizing misuse, while still, of course, appropriately managing the patient's pain. VCSQI has been providing updates and resources to you already through our biweekly updates and on our website. This webinar is our next step in bringing this issue to our participating practices. We expect to involve you all in an ongoing basis to meet the national call for action, and as importantly, provide you with resources and guidance that you seek to help address the crisis. We'll help you think about and make changes, including taking steps that align with patient and family engagement, improving health outcomes, and transforming your practice. This is a slide from the June presentation that we all heard from CMS. So, with nearly 140,000 clinicians participating in the Transforming Clinical Practice initiative across all 50 states, we should be able to make a collective impact for change. Certainly, the opioid crisis is bigger than prescribing and explained by many factors. The CDC reports on this slide that prescriptions to the person using opioids are explain just over 17% of their reported sources for the opioids. However, an additional 60% probably started with someone else's prescription. When you look at 55% coming from a friend or a relative at no charge, and 4.8% being taken from a friend or relative. One might even question if the 11.4% bought from a friend or relative began with a prescription. So this is why we must look at prescribing practices. Prescriptions are contributing to the availability and access to opioids. To that same point, many teens report getting drugs from their own medicine cabinets in their own homes. So this speaks to prescribing as well as educating those we prescribe to about not leaving their medications in easily accessible places. In addition, teaching them how to dispose of unused drugs is something that we all need to take on. So let's go to our guest speakers as we kind of look at this slide and think about an individual. These are pictures from CDC's website, by the way, who claims he was given a prescription that lasted longer than the pain itself. I'm pleased to introduce our first speaker, Dr. Robert Bales, from the Department of Family Medicine at Cleveland Clinic. Dr. Bales also serves on Northeast Ohio's task force that is addressing the opioid crisis in Northeast Ohio as well as the state of Ohio. Dr. Bales, please go ahead and share with us general issues to consider when prescribing opioids.
Great, thank you. What I'd like to do is first look at the first two slides are the actual schedules. If you could pull up, so these are the Schedule I drugs, which are currently have no therapeutic use, and the Schedule II drugs, which are the highest, with the highest addictive and abuse potential. Next one, please. And then we go down Schedule III, Schedule IV, and Schedule V. I put these slides in really for reference to just so people can see what is actually on all these schedules. Next slide, please.
Whoop, now I'm going too fast.
Okay.
There we go.
There you go. So I see patients more from a chronic condition, and so we see controlled drugs in general prescribed for things like anxiety, attention deficit, chronic pain issues, back pain issues such as failed back syndrome, spinal stenosis, and also, as a reminder, testosterone is a controlled substance. So men with hypogonadism are also being given controlled prescriptions. Next slide, please. So the question becomes, there is a role for low-dose narcotic therapy in some patients with chronic non-cancer pain. The hard part is, who is that person that can safely use an opiate for a long time? And I think some of these will translate into acute pain management, but I do come from more of the chronic pain management background. There is little evidence that we see quality of life improve, and it's one of the most common complaints that we see in family medicine and in general primary care is pain complaints. And we all know the use of opiates has been increasing. In 2010, they did a study that looked at about 20% of patients presenting to physician offices with pain were prescribed opiates. So 1 in 5 pain complaints was addressed with an opiate, and this is in 2010. And this came from CDC. Next slide, please. So a couple of tools I want to give everybody. We have often heard of narcotic contracts, and I put contracts in quotes because I want this to be the last time anybody ever uses the word contract. We should be using treatment consents or informed consent documents, which is an agreement between physician and patient on a treatment plan. There is a theoretical risk for calling it a contract in that if you breach your end of the contract, you could be sued for breach of contract, which by definition is not medical malpractice, therefore not necessarily covered under your liability insurance. And particularly at big institutions like here at Cleveland Clinic, we have robust institutional guidelines that guide how we prescribe, how often we see patients, what testing we do. So make sure you know your institutional guidelines. That really helps you to do this. Next slide, please. This is what I find the most difficult is your exit strategy. So what is going to be the end course of your treatment? Now, for something like acute pain, somebody who's in the hospital for surgery comes out, anticipates having 1 to 2 weeks of pain. You have a very limited therapeutic window. What we see, particularly on teaching services, is that residents are giving out fairly large number of narcotic prescriptions post-operatively to try to avoid phone calls down the road. So it's not uncommon to come out of particularly orthopedic surgery with 90 Percocets for every patient who leaves the hospital. So I think we do have room to look at those patients coming out of our hospitals, particularly coming out of our operating rooms, in limiting the amount of narcotic to essentially get the patient to their follow-up office visit, their post-op outpatient visit. There's a group of patients, however, called the term is legacy patients, and these are patients who have been maintained on narcotics for 10 or more years, some 20 years. And they've gone from doctor to doctor, and nobody really has a good solution on how to address, are they appropriate to be on narcotics? Do they need to be weaned off? How do you wean somebody off if they've been more than 10 years taking opiates on a daily basis? So this is a difficult group of patients, and I know a lot of my colleagues in family medicine, this is who we're seeing. Tapering doses, tend to think of a 10 to 30% dose reduction. So if you look at the total daily dose, 20% dose reduction is about what you want to do. And then I think, in my mind, to acutely remove patients from treatment, anybody who engages in fraudulent activity, so if one of your prescription pads goes missing and all of a sudden prescriptions show up on the street, anybody who engages in illegal activity, so if somebody is selling their prescription, giving it, sharing it, and I think any abusive behavior in the office or to other patients or to staff, I think those are grounds for abruptly just stopping prescribing. And I've had all these happen. Next slide, please. So what do you do with new patients? So a patient, moves from, say, New Jersey to the Cleveland area, has been maintained on narcotics, and now is requesting a prescription to be continued. And we see this fairly often, and I think there's some things you can do to protect yourself and also to make sure you're doing, practicing good medicine. So one is to get the medical records from where the patient has come from, whether it be a hospital, another state, another physician's office locally. Make sure you're using your prescription monitoring program. Here in Ohio, it's called ORS, but every state should have access to this through those state boards of pharmacy. So you want to make sure you're running the prescription monitoring reports before you prescribe for a new patient. This is the time when you should start with the treatment consent, and which then shares your expectations with the patient. Remember, we're not using contracts. And look at other modalities that have been tried. Are there options for non-narcotic treatment? And I also set the anticipation that the first day I meet the patient, they do not leave with a prescription until I, really gather some data on them and make sure I'm doing, I understand what I'm doing. Next slide, please. So I do an expanded urine drug panel. Now, part of this comes, I am also board certified in addiction medicine, and I have a fairly large addiction panel, particularly opiate addiction. Next slide, please. So I do two things. I do a urine toxicology, which is what you see on the left, which is a positive negative. The cut points on this test are higher. So for example, if you look at the cocaine, it's positive. And if you look to the right on the urine pain panel, these are quantitative numbers. You can see the benzocognaline, the third line down at 892, that's cocaine. So I actually get a quantitative as well. Just to sort of run these numbers real quickly, cannabinoids is marijuana, benzocognaline is cocaine, 6-acetylmorphine is heroin, amphetamine is general amphetamine, and then you see the breakdown, methamphetamine, buprenorphine is Suboxone, methadone is methadone, tramadol, fentanyl, codeine. We're all familiar with all these synthetic opiates. What I think is critical with the quantitative is it also gives you a urine creatinine, a urine pH, and a specific gravity. So these are three things to look to make sure that the urine that they actually put in the cup was actually urine. We also measured urine temperature in the office. There are also point-of-care testing products you can buy to use in your office. They give you an instant read. One thing about this that I wanted to show is that if you look on the toxicology, it says opiates negative. But if you look down, there's oxycodone and oxymorphone in the urine. Some of the urine toxicology tests only test for naturally occurring opiates, and they miss the synthetic opiates. So you have to be sure that your testing kit tests for both naturally occurring opiates. These would be opium, heroin, morphine, and also for the synthetics, the oxycodones and the hydrocodones. Next slide, please. So we touched a little bit on state prescription monitoring programs. These are programs in Ohio, it's through the Board of Pharmacy. In Ohio, we're allowed to have proxies, so my nurses and my medical assistants can run these reports for me. Next slide. This is just the front page of the Ohio reporting system. Next slide, please. So a few considerations when starting patients on, so this would be starting a new patient, someone who's opiate naive. So you want to make sure you're screening for substance use disorders, and you can do that through questionnaires or through history. You want to make sure you do a urine drug test. I always make sure that if I'm treating somebody's pain, I have had, if it's a spine issue, I have spine consult, I've done physical therapy, pain management plays a role in this. Always start low and go slow. So if you're going to start someone on, if you made the decision, I'm going to start someone on an opiate, 5 milligrams of hydrocodone twice a day is 2.5 twice a day, and don't push the dose very quickly. You want to be sure you and the patient are also clear on what are your treatment goals. And we really look at functionality. Are they getting through their day? Are they getting their ADLs done? Are they exercising? Are they engaging in activities that they want to engage in life versus treating to the pain score? And look at, what is our end point? What's our end game with this? How long are we going to use a narcotic? What other expectations do you have? Do you want to try other modalities like acupuncture, yoga, massage? Do you want to try local injections of joints? And then you have them sign the treatment consent as well. Next slide, please. Okay. And I find most docs struggle with, well, what do I do when I find a patient who actually is addicted? So the first thing is, stop prescribing. And also know what your local resources are. Is there a treatment facility in your region? Are there several in a nearby city? Where can you send a patient to get help if you suspect they have gone from appropriate use to inappropriate use of their narcotic? There is a thing called CBERT, Screening, Brief Intervention, and Referral to Treatment. It's through SAMHSA, so there's a link through SAMHSA that this is available. Anybody can take this course, and it gives you some screening tools for addiction, gives you some ideas on how to do a brief intervention to start the process to get them to a treatment provider who can help with the addiction treatment. I think this is really important. Anybody who's prescribing opiates with any regularity probably should take this training, and I don't think it's very expensive if it's not free. And then also learn, there are lots of educational materials, particularly through the American Society of Addiction Medicine, on developing your skills in treating this disorder. Next slide, please. One pain med I always like to mention is methadone. When I started treating addiction patients, I actually started off by running a methadone clinic. I'm very familiar with methadone. And this is not, in the methadone treatment world, everybody says this drug will bite you. Or methadone does not have a sense of humor. If you're not very familiar with this, I would not be prescribing this for chronic pain. You particularly have to be wary of the prolongation of the QT segment. Therefore, everybody needs EKGs. And it has a variable hepatic metabolism, actually with an increasing potency as you go up the dosing range. So going from 0 to 100 is not as potent as going from 100 to 200. So it has nuances that really, unless you're very, very familiar with this drug should just be avoided. It also has one of the highest overdose death rates. Next slide, please. And that's what I've got for comments.
Okay, please, thank you so much, Dr. Bales. If you've got questions for Dr. Bales, keep note of them or put them in the chat box. We will have time for discussion shortly. Now we're going to hear from Dr. Jared Skilling from Spectrum Health System, where he's Chief of Psychology and on the faculty at Michigan State University's College of Human Medicine. Dr. Skillings is a psychologist and experienced in the area of non-pharmacological approaches to pain management, and that is what he's going to be speaking to us about now. Dr. Skillings, take it away.
Thanks very much. Very glad for everyone to be able to be here and have a chance to speak with you and to be able to listen to Dr. Bales and Dr. Rich and yourself, Dr. Nazem. So let's go to the next slide, please. So what I'd like to emphasize first, when we talk about non-pharmacologic approaches, what I'd like to do is paint a broad picture. And so what I've done in my work when I talk about to medical residents or to other providers or even staff who are non-clinical is to talk about or encouraging them to wear a white coat. So what I usually say to other physicians, especially residents, is to wear a white coat in your mind, not just on your back. That was something that one of the residency directors during my fellowship suggested. And what that means is, you can see the picture here. So when someone comes in and they're demonstrating signs of abuse or they're demonstrating behaviors that just make you wonder, is this really, is this not the right kind of prescription? Are they using it in inappropriate ways? Is there some chance that they're behaving in weird ways or it's affecting them in regards to side effects that you might not expect? Just be aware of that in a broad way, because part of our challenge here with the opiate crisis is, of course, as Dr. Rich nicely said earlier, the number of prescriptions that are going out on the street. But at the end of the day, it's about the patient's functional level and their ability to function, and the fact that people are becoming addicted and then getting into heroin and even stronger substances. So always think about this like you have a white coat, or keep the doctor focus in the way you're interacting with patients, even if they're coming in for non-clinical relationships or they're not having a clinical encounter. Next, please.
Oops.
Thank you. So what I wanted to highlight first is what the purpose of some non-pharmacologic treatments, particularly for abuse, but also just in general. First of all, the treatment, the main purpose of the treatment is, first of all, number one, to work on treating any kind of substance use disorders. So that's at the most extreme end of the spectrum. So folks who have already worked their way into an addictive process. And so when we talk about from a non-pharmacologic perspective, what we're really referring to is asking the patient to make a huge array of changes in their life. So that's everything from changing a lot of behaviors around the addiction behavior itself, changing their beliefs. So sometimes there's a number of patients who have beliefs around the use of opioids that are really problematic. They believe, or because they have become addicted, in real life, it is actually much more painful for them to even wean off of the medications, that they have catastrophic beliefs around those kind of changes, that they won't be able to function or that their life is going to fall apart. So in order to change those kind of abuse behaviors, we really have to not just get to the behaviors, but the beliefs that are behind it. Next, we also want to look at this from a social network change. So with any addictive process, anything from stopping cigarettes to slowing down your drinking to stopping opiates, there's almost always, if the addiction gets to a severe place, a need to change the way that your social network functions. A lot of times people have connections with other people who engage in the same behavior, or whether they know it or not, are reinforcing, or either subtly or really overtly, the behavior itself. So again, big picture, we're talking about the treatment of addiction, broadly speaking, can require a lot of changes for people. And secondly, it's not just the treatment of addiction we're talking about, but it's also the treatment of other kinds of psychological conditions or other kinds of potentially social situations that may be impacting the need, maybe impacting the person's need or perceived need for opiates. So, for example, if a person had been in a traumatic event, no doubt any providers on this call or even other staff members will be aware that patients a lot of times have very clear underlying reasons why they overuse substances. Sometimes they also divert the substances, not just take them, but they also divert them. So either personal abuse or diverting the substances, there's often really clear either psychological or social reasons. So a patient with trauma, for example, you need to really address the trauma, or you need to address the underlying anxiety condition as well. And then number three, again, thinking about the purpose of non-pharmacological treatments, one of the things we also need to be aware of is that, of course, patients will also have, a lot of patients who get addicted have had some kind of experience of pain, whether that's an acute process or a more chronic process. Of course, sometimes that's a process that we've created in the medical system as well. So however that is, we need to work on not just managing the addiction issues, the broad psychological issues, but also the actual physical, biological pain pieces of this puzzle as well. Next, please. And if you're working with somebody who is going through a treatment process, part of the challenge here, and there's a balance. So I'm not a physician. I'm a psychologist. So I'm not going to offer any prescription advice. I'd be very interested to hear what Dr. Rich and Dr. Bales would suggest. But the way I have tended to think about this is there's a balance with when you think about trying to wean someone off of medications. If you know they're addicted, part of the challenge is if you don't find someone to help them through the withdrawal process, there's research showing the patient is much more likely to relapse. So as a physician, of course, you have an ethical obligation to not continue to prescribe medications to people who you clearly know are addicted, and yet at the same time, the difficulty, the dialectic actually, the difficulty is that if you cut patients off immediately, or frankly, if there's no other way, if there's no other way to manage the withdrawal symptoms, or there isn't some kind of a holistic care model about managing the withdrawal symptoms, the patients are much more likely to relapse because of how uncomfortable and how unpleasant that is. Next. Now, what I decided to do was focus today on very quickly on the psychological kinds of treatments that you would use for opiate abuse or opiate diversion. Dr. Bales earlier highlighted a number of non-traditional techniques. So for example, there is some nice literature around the issues of acupuncture for the treatment of addiction issues and chronic pain. So I'm not going to focus on those. What I did want to highlight is that there are really three ways to deliver services that are more psychological or psychiatric in nature. That's group therapy, individual therapy, and then community treatment. And patients, of course, can be referred to any of these. So what I would suggest is that in your own area, that you look at and have an easily identifiable list of the resources that are available in your community, particularly in rural areas. This is an impressively troublesome challenge. In rural areas, you may have one or two behavioral health providers, or you may or may not have something like Narcotics Anonymous. There may be an Alcoholics Anonymous group that meets at the local church, but there may not be Narcotics Anonymous. So in rural areas particularly, you really have to make sure that you identify what resources are available. And even though, especially in a case of very clear abuse, opioid abuse, you want to refer to a licensed professional, I've known some circumstances where there are layperson groups that provide support, and the layperson group is really the only option for treatment. And so you need to think about this from a holistic perspective. Last suggestion before we move to the last slide is I would also suggest from a holistic or non-pharmacologic approach that you want to think about the patient's worldview, broadly speaking. So if a patient has a particular spiritual bent, a lot of times, I'll just use an example because it's the majority religion in our country. So a lot of times if somebody has like a Christian bent, there are some larger Christian churches, especially if you live in a larger metropolitan area, that have and run addiction groups, or they run other kinds of layperson focused groups, or sometimes even groups that are run by a professional that provide support that might be consistent with their spiritual orientation. Now, of course, that's also true for other kinds of religious experiences, whether it's Islam or Judaism or otherwise. So that's something else from a holistic perspective to think about. How does the treatment connect them into their community from a spiritual or community perspective? Next, please. There's also a number of treatment techniques. So this slide gets into the weeds just a little bit more about the kind of referrals that are evidence-based that you could consider from a medical office to refer patients for. So if a patient is clearly in an abusive spot with their opioid use, one of the techniques that has become very popular, both to train physicians, PAs and NPs and other medical staff, as well as, of course, behavioral health practitioners, is called motivational interviewing. What that is that is supposed to be, if it's done correctly, a process that's very collaborative, where the provider does not take an argumentative or a formal, no, you can't take these medications sort of stance, but instead has a more collaborative approach where you slowly walk the patient through what are the reasons for why they're using and why that has or hasn't harmed their life. And it's a more therapeutic, softer approach, which actually has a very strong evidence base. It actually started in the alcohol treatment literature, and it's been broadly applied to all kinds of health behaviors, everything to diabetes, and now, of course, opiate abuse as well. The next two you may also have heard of. The first one is mindfulness-based stress reduction. So this has to do with being more mindful of your surroundings and helping people not to get caught up in triggers that might cause them to use too many substances or to overuse the opiates. And lastly is cognitive behavioral therapy, which in its traditional form is really either delivered online, which usually is for a particular indication like depression. To the best of my knowledge, there isn't any robust treatment program online yet for opiate abuse, but that would be a really nice next option for us to be able to develop countrywide. Broadly speaking, cognitive behavioral therapy is working with the patient and their family, if necessary, to be able to help the person understand the connection between how they think and how they behave. Next. And a couple of notions around practice management. So our other two experts had talked earlier about, I like Dr. Bales' use of the term contract and why that doesn't make any sense. In fact, really what we're talking about, I think, to reframe it just a little differently, is the expectations that you have as a provider, either a medical provider or a behavioral health provider, so that you have clear expectations and that the patient is not simply caught off guard when you change prescription processes or treatment guidelines in your office. So what you want to do is you want to make sure that at every stage of change that you have, so if your practice is moving towards a more strict process around opiate prescriptions, then you want to make sure that the patients are informed about that. And that as a provider, you want to have that conversation with the patients. I've heard a number of patients who complain that they get a piece of paper in the mail and that they hear from what seems like Big Brother telling them that their medications are getting cut off, or somebody even made a comment in our chat box that says that pharmacies are now starting to put limits, which I have also understood too. And insurance companies are now starting to get into this health plans, so they're starting to limit what they will and will not reimburse. So sometimes patients will show up at the pharmacy and they will not be able to get the prescription or not as much as they thought. And so as much as possible, it's important to try to, as individual providers and administrative office staff, try to be able to make sure that we clear that and explain that with patients so that they know, frankly, I'll tell you the way I would say it. What I'd be more likely to say to patients is, we're in this spot where we have an opioid crisis in our country, and there's a lot of moving parts right now as we try to get our hands around this. And so there may be a time when you go to your pharmacy and they say something different than our office does. Please just call us. We'll try to work this out with you. That's going to feel a whole lot better if a provider or if the office manager says that to a patient than if they're surprised by it. And the last piece is to work on developing policies and procedures that are standardized. Part of the challenge, as you all know, is that there are some providers that are looser around this issue and lots of other issues than some of the rest of us are. Some providers are very tight and very stringent. Some providers are very loose. And that isn't to demonize or to get after anybody particularly. It's just the way this functions. And so part of what you want to do is you want to be able to help the providers who are too stringent to be able to look at what the therapeutic value of opiates is and when they should be used appropriately. And you want to use the providers that are too loose, which is really the main problem we have right now, to tighten it up and to be able to pull that back. And so that's why we need to develop not only policies that are consistent, but we need to have ways that we figure out if people are actually adhering to them or not. So this issue around policies and procedures is a change management process for all of us who provide direct patient care. It's a change management process for the office administration and for the direct office staff, including the people who answer the phones, who are the very first point of contact for any patient. So there's a lot of change management processes across our whole system, not just within the medical and healthcare arenas that we actually provide the care, but again in pharmacies, frankly in other kinds of community centers as well. I mentioned earlier churches and whatnot. So from a practice management point of view, there's a lot of work that you need to do to make sure that everyone's on the same page and that everyone can be accountable, but in a way that's reasonable so that patients are on the same page as much as we can help them to be that way. Next. That's it.
Okay.
Back to you.
Thank you, Dr. Skillings. So now we can open up for discussion. You can feel free to continue using the chat box or start using the chat box or unmute yourself and ask any of our experts questions or simply make comments or share your experiences. And I think while we wait, I'm going to ask Dr. Rich, are you still with us, Dr. Rich?
Yeah, hi, Debbie. I'll jump in. Just a few thoughts that I jotted down while I was listening. I mean, personally, I've been in that situation with orthopedic reconstruction, back surgery, knee surgery, and I've been overprescribed excessively between 90 and 120 Percocets or hydromorphone tablets. And I've never taken any of them. I've returned them back to the prescriber and said to please take a course in prescribing appropriately for patients. And maybe I have a high level of tolerance for pain, and that's fine. Seema Verma, the CMS administrator, was here last night and shared the stage with Toby Cosgrove. She brought this forward as an incredible national emergency almost. They're trying to craft legislation. If Trump declares it a national emergency, there's going to be funding to bring this forward to providers and patients, you know, as an educational enterprise in the United States. And finally, just for all of you listening from Virginia, Virginia also has a monitoring program as well. So if a patient comes into your office and you can easily pull up the statewide registry or the Commonwealth-wide registry of, you know, their prescribing patterns and the prescriptions they've had. So you can clearly identify patients who are out there shopping for drugs or for opioids. So thank you for allowing me to say that.
Thank you. Yeah, most states have a prescription drug monitoring system, and increasingly they are sharing them with each other so that you would be able to even see if a patient has been getting prescriptions in other states. That also is something that is being encouraged for each state to open up their monitoring systems for that purpose.
And I'd look to our experts, you know, from Ohio here, Dr. Bales and others. The I'm working with the general surgery resident who really wants to look at prescribing patterns for patients who have had surgery. Problem is that in Ohio, you cannot access prescribing patterns for patients unless you're taking care of them. So if I do coronary artery bypass on them and they're out of my care after 30 days, I can't figure out if they come back to my office in 6 months whether they've had any prescriptions done by anybody else because they're not under my care. And so what we were hoping, and Dr. Bales can speak to this as well, that we would get the state legislature here in Ohio to allow us to have chronic monitoring of prescription writing for patients who have had their very first prescription. And I don't know if that resonates at all with you, Dr. Bales, or how you feel about that.
Well, to a certain extent it does. I guess I'm in the unique position of I'm a primary care provider, so nobody's ever out of my care, unless they just choose a new primary care. I know there has been some initiatives to try to tap into the ORS database to almost go in and data mine and look more proactively for people who are displaying patterns of abuse, independent of the prescriber going in themselves. So that's been put forward, and I think that's that's something that's important. Is that how do you know that somebody else isn't also prescribing when you've sort of closed the case?
Right. And I've had that, where people do doctor shopping. They come to my office, and in all honesty, I've prescribed an opioid once in 25 years as a cardiac surgeon, but I would refer them on to somebody like yourself or pain management if they came to my office looking for more opioids. But when our database became available, I was seeing patients coming back who just had received a prescription from another provider, from a urologist, from PCP. It was pretty evident that people were shopping for narcotics, from provider to provider.
I'm going to move on and talk a little bit about the measures because it might generate additional discussion. Okay. Measures that we're contemplating asking our participating practices to use. So you see, this is proposed practice level metrics. There are 3 measures listed here, and all of them are on the Quality Payment Program website of CMS. So they're even available for selection to meet the MACRA and MIPS, reporting requirements. So you see, the first looks at all patients 18 and older prescribed opiates for longer than 6 weeks duration, who had a follow-up evaluation conducted at least every 3 months during opioid therapy, documented in the medical record. So you would be tracking your patients 18 years and older that you've prescribed opiates for, and at least every 6 weeks document that you did a follow-up evaluation. The second measure is documentation of a signed opioid treatment agreement. Again, all patients 18 and older prescribed opiates for longer than 6 weeks durations who signed an opioid treatment agreement at least once during opioid therapy, and it's documented in the medical record. And then the third, also one of the quality payment program measures, is evaluation or interview for risk of opioid misuse. All patients in the same age group prescribed opiates for longer than 6 weeks duration evaluated for the risk of opioid misuse using a brief validated instrument or a patient interviewed, documented at least once during opioid therapy in the medical record. So from this, we can generate a VCSQI level rates, as well as understanding the % of our participating practices that actually have a prescribing protocol. So I guess I would like to ask both Dr. Bales and Dr. Skillings, are you familiar with these risk assessment tools that are used to, assess the patient's risk for addiction? And what would you say about them if you're familiar? Dr. Bales, maybe you can go first.
Yes, I'm familiar with them. I think they're good tools to use. I also would add to this that, you know, urine drug screen is a very important tool as well. These are pretty standard. You know, this should be the mainstay of opiate therapy, these three bullet points.
Okay, Dr. Skillings?
Yeah, thank you. I think those are good points. First, the tools. I'm not as familiar with the opioid risk tool, but I am very familiar with the SOAP-R. That's quite a nice measure for patients who are opiate naive. There's another measure for patients who are currently being prescribed opiates called the COMM, C-O-M-M. I don't have it in front of me. I wasn't prepared for that today. I'm trying to remember what that stands for. Opiate misuse measure, I think.
Okay. Maybe we can look it up and provide more information then.
That's quite a helpful measure for patients who are actively taking opiates. But both the SOAP-R and the COMM are self-report, so it's the patient's perception of how they're doing, and then they're quite nicely predictive of whether a patient is either will or is abusing. But I would echo Dr. Bales' suggestion about a urine drug screen. In addition to reviewing the patient's prescription history. So in Michigan, for example, we have what's called MAPS, the Michigan Automated Prescription Service, which reviews the process of getting medications. And so if you see a deviant pattern or deviant drug screen and or risk factors on any of these measures, I would think as we tend to look at it, those would be four good ways of looking at it.
One other thing to consider is a depression screening like the PHQ-9 and the GAD, which is for anxiety. Patients with depression and anxiety disorders inherently have a higher risk of opiate misuse.
Okay. We can get more information about those tools out to our listeners and participants. Does anyone have any questions on these measures? Okay, well then we only have a few minutes left. So this is the conclusion slide from the CMS presentation I mentioned earlier. Obviously underscoring the urgency to address this issue, and that is it is continuing to evolve, so we'll have to continue to evolve our approach to prevention. There are federal and state and local partners to be contacted. And we've been compiling a list of state regulations for the practices in the states where we have practices. One thing I would just note is that the Texas State Board of Pharmacy has done has made some incredible videos that are aimed at helping community pharmacists spot potential abuser of opioids. And this may be a patient who comes back to you, the prescriber, upset because the prescription would not be filled. But I would encourage those of you who are interested to see what community pharmacists are seeing about how to play a role in reducing the use of opioids. Finally, I just want to say that we will be conducting a survey of our participants to gather more information about your current prescribing protocols, whether you do use a risk assessment tool, whether you have a protocol, etc. So watch for that. The link will come to our primary contact via an email. And we'll conclude with taking the pledge. When you get the slides, and we'll send them out with a link to the recording of today's webinar, be able to click on this link. It is a pledge that was developed by TCPI's Medication Management Group, asking you to take a pledge to educate yourselves, your team, to ensure that persons who do have an opioid use disorder are treated in a respectful and person-centered manner, to leverage and align with existing programs and initiatives, and identify and report on successes with those of us that are working across the nation to mitigate this problem. And there's a link, obviously, on this slide, too, to read more about this campaign. So again, I would like to thank our speakers, Dr. Rich, Dr. Bales, Dr. Skillings. Thank all of you who participated, and stay in touch. We'll be sending you more information. We do want to hear more from you about other topics or expanded discussions on any of the topics briefly highlighted today. We tried to fit a lot of high-level overview into one webinar as a start.
Thank you.
Okay. Thank you. Have a good evening, everyone.
Thanks so much.